So hello and welcome to our webinar today. The topic is intervertebral disc disease. So my plan is to walk you a little bit through slip discs and the topic of slip discs. So for the next 45 minutes, we're going to cover some of the most important factors. And then in the end, I'll have like 10-15 minutes time to answer questions. And to whatever question I will not get to, just want to say straight ahead, well, obviously, I can cover them via email. So if you just want to keep sending those questions, and I'm very happy to answer them via email even over the next day or two. Also, not to forget, about an hour after the webinar, you're all going to get a CE certificate sent to your email, so you have some proof of attendance as well. So first, want to start off tiny bit to introduce myself for whoever doesn't know who I am. So my name is Franziska Fitz. I'm originally from Germany. I've been born and raised there, and brought up in a farm, like with my father being a veterinarian as well. So I guess the passion, or I love for animals, is genetically embedded. I started my journey to become a veterinarian myself when I was 19. So I left Germany for that. And after vet school, slowly made my way over to the United States. There I eventually met Dr. Wong and started to train in neurology, neurosurgery. And now many years later, I'm one of the neurologists here at Southeast Veterinary Neurology, and I'm a proud team member and happy to be part of that team. So that's just a tiny bit about myself, and I guess we'll get started with the more important parts. So I want to start today's talk with that tiny video. So this is a very young male neutered French bulldog. His name is Neilman. Dogs like him, this it basically is the reason what we do for what we do. So obviously, as you can see in this video, how Neilman is unable to move both of his back legs. Given the fact that we talk about slip discs, he obviously had a slip disc, but dogs like him are the reason for what we do here at Southeast Veterinary Neurology. So these are quick the bullet points of what I'm trying to cover today. If we are running late, we can skip the case report, for example, that we have more time to answer questions in the end. But at least I want to review some of those bullet points today. So let's start first with the anatomy. So the anatomy of the intervertebral disc is very busy. There are lots of structures, many important structures, but how I typically describe it to an owner is a disc is like a donut with a jelly inside part. So the donut is the part of the collagen or the cartilaginous ring, which is kind of layered like an onion, and it has like fibrous structures which are holding the disc in a circular shape. It is embedded into the adjacent end plate. So this is how the annulus gets firmly in between two vertebrae. And inside the annulus sits the nucleus. So the nucleus pulposus is usually a very hydrated material. So this is what we refer to as the jelly part of the disc. It's glycosaminoglycans and chondroitins, which keep it so moist and gelatinous. And so this is how it's meant to sit. The caveat on a intervertebral disc is that the dorsal part of the disc, or the dorsal part of the annulus, is a little bit thinner than the ventral part, which makes the nucleus sit eccentrically more dorsally. And so how you can appreciate that on the image here I displaced on that type of slide, that the nucleus is a tiny bit more eccentrically located. So this is the annulus, the outer ring. The inner side, the jelly part, is the nucleus. It is sits on the end plates of the respective cranial and caudal vertebra. And the disc is dorsally and ventrally bordered by some ligaments. So we call it the ventral and the dorsal longitudinal ligament. Those ligaments are essential for us to recognize an anatomic location when we do surgery, but the important part is they keep everything very rigid and in where it's meant to be. And the other ligament, which is very important actually, is the intercapital ligament, which is the ligament between the rib heads. So between T1 and T10, we have this intercapital ligament, which keeps the whole chest cavity a bit more rigid. And that's also the reason why slip discs usually don't happen cranial to T10, because the intercapital ligament helps somewhat to not have a disc slip out by itself. Generally, the annulus and the nucleus so the nucleus is not innervated, but the annulus is innervated. So if the annulus ruptures, this is why dogs hurt when they actually have a ruptured disc in what we call discogenic pain. But we'll get there once more in a later slide today, but that's kind of a little bit the broad anatomy to the disc itself. The anatomy of the spinal cord is somewhat different as well to what we maybe expect. So the vertebral column, this is how we call the entire structure. The vertebral column is basically all the vertebrae which align as a chain and form the vertebral canal, as like the bony encasings. Inside sits the spinal cord. The spinal cord itself is made out of segments. So each segment gives rise to a pair of spinal nerves, which leads through the intervertebral space, the intervertebral foramen, and then obviously to the respective place where it needs to be for innervation. Not in each vertebrae we though have the respective segment, and this is anatomically a little bit complicated because when we localize dogs, we localize them to the segments, but when we do surgery according to the vertebra. So kind of it makes it a little bit more messy, but it's just for us important to recognize that not each vertebra has its respective segment. So the spinal cord is shorter than the vertebral column. This is embryologically because they come from two different origins when the dog or the cat develops in utero. So in a large breed dog, the spinal cord ends as soon as in L4 actually already, versus in cats or small breed dogs, the spinal cord can go all the way caudal until L7. So pathophysiologically, what happens to the disc actually? So why do we have a disc? Because it helps us to support and distribute the loads. So we all move around a lot, our dogs even more so. And the intervertebral disc permits actually a stable motion of the spine so that we can be so flexible, jump up and down, and don't have any concussive injuries to the spinal cord on a normal day-to-day basis. But what happens over time is actually that those discs become senile changes. So the collagen fibers slowly disrupt the jelly part of the nucleus, so what we called earlier the inside jelly part in our donut, slowly gets more dry, it loses its water content, it forms into more cartilaginous type of appearance. So that obviously those changes are a problem itself. And then what happens, and this is what this picture is trying to show us, that so we have the normal senile changes over lifetime, in some dogs younger, in some dogs older, but now the already weakened disc has additional stress by just being an active, normal dog. So jumping up and down the couch is a major strain on an already weakened disc. And this is kind of, it's like a vicious cycle. So the disc is weak, they jump up and down, they put stressor like micro trauma onto those weakened discs, and this is what causes those discs to rupture out. So kind of the whole circle is what's the problem, and I think this image represents exactly actually what happens on a microscopic level. So this was a bit just the introduction of the anatomy and the pathophysiology to get a bit of a background knowledge. Why is it also important to know also the anatomy and the pathophysiology? And now let's review a little bit of the anatomy. So the neuroanatomy is important because we need to localize animals. This is obviously one of the major jobs we do as neurologists, is we localize where's the problem coming from. So kind of just very broadly, in general, everything is being either localized to an upper motor neuron system or a lower motor neuron system. Upper motor neuron is everything what controls the lower motor neuron. So can be the brain, the medulla oblongata, the spinal cord itself, and then the parts which give like the parts which control the lower motor neurons. So when we have an upper motor neuron injury, our reflexes are normal or increased. The muscle tone is normal or increased, and muscle atrophy is very mild. So just sometimes you can have some disuse atrophy, but typically the most important part is to look out for, are my reflexes normal or increased, and is the muscle tone normal or increased. Lower motor neuron, on the other hand, is now the spinal cord intumescence, so where the lower motor neuron, the ventral horn nerves leave the spinal cord, the nerve root itself, the nerve axon, and then we have the neuromuscular junction and the innervation to the muscle itself. So that all together is considered a lower motor neuron. When the injury happens in a lower motor neuron, what we see are actually decreased reflexes or even absent. The muscle tone very quickly becomes decreased or flaccid, and muscle atrophy is rapid. So denervation atrophy is within a couple of days to tops a week that we see noticeable changes in atrophy of the muscles. So that's just very broadly, and also here the image on the right-hand side of the screen shows that we have upper motor neuron and lower motor neuron. So whenever we see a dog with a back or neck problem, it has to be categorized. So this is where this picture is coming in, just to do a tiny bit of an exercise. If we have a lesion affecting here small letter A, so the dark blue part of the spinal cord is a C1 through C5 myelopathy. So this is a type how we localize. I expect that also my thoracic limbs and also the pelvic limbs show signs of upper motor neuron deficit. So we have normal reflexes in all 4 limbs. We have normal muscle tone in all 4 limbs. Versus if the problem is coming from the small letter B, so the green part, this is a C6T2. So this is the cervical intumescence neuroanatomically. Here I would expect, because it's affecting the lower motor neuron of the thoracic limbs, but it affects the upper motor neuron of the pelvic limbs. So I expect to have weak reflexes in the thoracic limbs and normal reflexes in the pelvic limbs. Versus if the lesion comes from the small letter C, so the yellow part, this is a T3 to L3 myelopathy. My thoracic limbs are normal because it's behind them. So they're obviously not affected anymore, but it's an upper motor neuron lesion to the pelvic limbs. So the pelvic limbs have normal reflexes and normal muscle tone. And then an L4S3 myelopathy, so the red part here with the letter D, is a lower motor neuron localization to the pelvic limbs, so decreased reflexes, decreased muscle tone. So that's step 1 in our neuroanatomic localization. So kind of after we determine where, is it a neck or a back, and then in the neck, is it a C1 through C5, a C6T2, a T3L3, or L4S3. So this is the first step, that we determine where. The second step is that we determine how severe. So we always categorize every spinal cord injury in a dog on a scale of 1 through 5. 1 is the best, 5 is the worst. And the reason is simply because anatomically where our pathways are located along the spinal cord, this is from the most outer, like peripheral part, to the most inner central part, if the compression is more or less in severity. So kind of to walk you through, number 1 is hyperplasia, so spinal pain only, neck pain or back pain, but there's not an actual neurologic deficit. Category 2 means the dog is ambulatory, but it shows signs of ataxia or paresis. So the difference is ataxia is the unawareness, so the sensory unawareness in space. So kind of a proprioceptive ataxia, they leave their paws knuckled over, they are not aware that their legs are sliding out and are not supported exactly under their body. So like a proprioceptive ataxia. Versus paresis means weakness. So this only means that they are a little bit too weak to actually walk normally. Their muscles are too weak to really have them function normally. Category 3 means non-ambulatory. So here the motor function is still preserved, but the animal needs assistance. So with a little bit of a lift, with my hand under the belly or under the chest, we give enough support and kind of guide them through over a yoga mat where they have good traction. They can still move their legs, but they're not strong enough anymore to get up and walk by themselves. Category 4 means that the animal is completely paralyzed. So whether this is paraplegia because it only affects the back legs, or it's a tetraplegia, it affects all 4 legs. But deep pain perception, so the ability to feel the legs, is still preserved. And then at category 5, the worst category is being paraplegic with absent deep pain perception. we always test that first just with the fingers, so you try to really forcefully cause some discomfort between the toes. And if the animal does not react, we then use a mosquito forceps actually and go really to the bone, clamp the mosquito forceps. So the most important part though is to realize that deep pain perception is a conscious response, and we'll get there once more later on. It is not a reflex of pulling the leg back. It's actually the animal needs to complain of like, oh, that hurts me, stop doing that. So this was just a little bit to give you an introduction. We covered some anatomy, we covered some pathophysiology, we covered some basic anatomy in neuroanatomic localization. And now let's talk about the actual intervertebral disc disease. So it is the most common spinal cord disorder in dogs by far, and other names are commonly used as disc herniations or slip discs or pinched nerve. Owner loves to hear pinched spinal cord. So those are all same analogies to the same problem. There's actually many studies, or there are many studies performed on how often do we see that. Turns out 1 in 5 dachshunds have a slip disc once in a lifetime. Another relative new study actually showed that 1 in 4 Frenchies has a neurologic disease, and of those actually 70% have a spinal cord problem, and with the most common being a disc disease. So it is super frequent that 1 in 4 Frenchies presented to the vet actually has a neurologic disease, where most of them, so 70%, have slip discs. So super common problem. This is why we take so much focus on the intervertebral disc, and this is also why I want to inform you today a bit more about that. So there are different types of discs. So we said slip discs, herniated disc, pinched nerve, it's all kind of the same thing. For an orthomose, typically yes, but for us neurologists, actually not, because different types of discs are treated differently and have different prognosis. So this is why it's quite important we differentiate between those 4 types, and we also identify them. So we'll go through those types and how we identify those different 4 types. The first type, and it's the most common, and this is why I want to talk about that type first, is called a type 1 disc extrusion. And what it is actually the nucleus pulposus here is the problem. So the nucleus pulposus, we said in the beginning, is the jelly part, is the glycosaminoglycans, is the high water content bouncy part within the disc, which loses water content, so it becomes calcified. It actually turns into cartilage. The annulus is still actually fine, and the annulus wouldn't be the problem. But we have that really rigid nucleus sitting inside the annulus. And now our dogs have those micro traumas, like jumping off a couch, for example, which seems quite innocent, but it's a major impact for that rigid nucleus. It just ruptures out of the annulus and with full speed comes up from ventral into the spinal canal. So this causes a couple of problems. One, we have degenerate nuclear material now within the vertebral canal. The vertebral canal doesn't have more space than just host the spinal cord, so obviously causes a compression on the spinal cord because we added nuclear material where there's no space to add nuclear material. The second problem is it's a hard calcified structure which comes out with relative force. So it causes an injury on the spinal cord, so like a bruising or like it smacks the spinal cord. So that injury can cause bruising and can cause secondary changes to the parenchyma. And also, so the third problem is that the nuclear material is actually immunoprivileged. So it's not recognized by the own body. So it causes an inflammatory reaction because now we say, okay, there's something in the vertebral canal which shouldn't be there. The body is always trying to heal everything, so it causes massive inflammation. We see that most often in chondrodystrophic breeds like Dachshunds, Frenchies, and so forth. And actually, Dachshunds are prone to have that in even young ages. So the chondrodystrophic breeds are a bit predisposed or prone to have an early degeneration of the nucleus. This is why we see such young dogs with disc problems already. But it can happen in other dogs, you know. So we see plenty of German Shepherds, Labradors, Dobermans, and Rottweilers with the same problem, and it's the same like degeneration of the nucleus. So they are not spared from that. Type 2 is called a disc protrusion. So here actually the nucleus is fine. The problem here is the annulus. The annulus is slowly being replaced by collagenous tissue, so it becomes hypertrophic. So the annulus gets bigger and bigger and bigger, and then it doesn't fit anymore into the space it has been given, where in between the two vertebrae. So the increase in size of that annulus slowly from ventrally occupies some space of the vertebral canal, and then slowly from ventral compresses the spinal cord. So this is why it's not as acute and traumatic as the type 1 disc. What we see, it's more like a progressive and chronic, slow developing condition. And that is more typically like the all degeneration, also the type discs we know from human medicine. It's the things we know from the large breed non-chondrodystrophic German Shepherds. And because the nucleus is not the problem, they're also rarely mineralized. So that's the ins and outs to the type 2 protrusion. The third type, so it's, some people call it type 3. Technically, it's not identified by the same person, so this is why we actually don't call it type 3 disc. It's rather called an acute non-compressive nucleus pulposus extrusion, or an ANNPE. What the problem here is that it's a high velocity but a low volume disc extrusion. So extrusion means the nucleus ruptures out with a very high velocity, so high speed, but actually to a low volume. So the difference to a type 1 disc is that it hasn't been degenerated. So we don't have actually the calcification of the nucleus. It's just that those animals had some high intense exercise or trauma. So they played frisbee, they jumped up in the sky for a couple of feet and then fell to the ground. Or very often we see this in working canines when they have to jump walls, or border collies actually are a bit prone. So those discs are just placed under a very great stress, which the annulus just can't handle. And this is why fresh, non-degenerated or non-dehydrated nuclear material with real high speed ruptures out of the annulus and causes a rather concussive injury to the spinal cord and not so much of a compressive injury. So the big problem here is the concussion or the bruising to the spinal cord rather than a compression. So this is why it's peracute in onset, usually doesn't progress, and often we actually see this with lateralizing signs. So that's kind of the hallmark of that type of the slip disc. So why I want to show you this MRI specifically is because an acute onset lateralizing sign in a young sporty breed dog could also easily be an FCE, but it obviously should be differentiated from an ANNPE, because what we do after the diagnosis is very different. FCEs are enrolling in physical therapy very aggressively, versus ANNPEs need to be very, very strictly rested, because here the disc has an injury and there's a risk for further extrusion of nuclear material, which then would cause some compression. So this MRI, so kind of to just get you an idea where we are at. So dorsal is on the top. Here on the left, this is cranial, the bottom is ventral, and the right is caudal. The black here, what I'm pointing out with the arrow, is the spinal cord. The white line on top of the and on the bottom of that spinal cord is the CSF in the subarachnoid space. The bright oval-shaped structures here, these are the discs. So this disc is actually not as bright, so it's a bit degenerate already. And this disc has a bit shrunk in size. So this is where the small volume slipped out. So this is why the volume is not anymore as big, because some small volume of the disc has ruptured out, but it caused rather a concussion. So the hyperintensity obliquely here within the spinal cord is the injury, and we don't actually have a real compression. So the line is almost complete. So this is kind of what we see on an MRI scan when we diagnose an ANNPE. And this is now the fourth type and last type of slip discs. What I wanted to chat with you today is called an acute compressive hydrated nucleus pulposus extrusion. So we always have those fancy huge terminologies, but kind of it's again hydrated, the what ruptures out. But here actually some of the nucleus pulposus has extruded and causes a compression, so hence the name. And some call it a discal cyst, or like a cyst-like structure, because it's so hydrated that it almost represents a cyst. Obviously, it's not a cyst. So here what happens if you have hydrated nuclear material, it ruptures out, but it does cause a compression. We more often see this in the cervical spinal cord as opposed to the thoracolumbar spine, but it is reported most commonly actually in the thoracolumbar junction. It causes very, very severe motor impairment, not so much actually pain. So how we usually see animals, they are from 1 minute to the other one tetraplegic, but they're actually not so painful. Usually they have a hydrated disc and a hydrated nucleus pulposus extrusion. The MRI is very classic as well. So here's the MRI. This is now a transverse section. So the spinal cord is here, that area. So it's kind of going behind into the screen. So again, we have the two lateral aspects, so right and left. This is dorsal and ventral. This is the spinal cord. The CSF surrounds the spinal cord. And here we have that bilobed seagull-shaped appearance of the hydrated nucleopulposus extrusion. So this was just an information of the 4 different types of slip discs which can happen. Now, what do we see actually clinically when a dog presents with a slip disc? So it can have quite a variable appearance. So it can be acute, we said, you know, with the nucleus pulposus extrusions, but can be chronic if it is rather a protrusion. It can progress if more and more disc ruptures out. It can be symmetric or asymmetric, as we said, and it can cause quite severe pains. The most important is to localize the lesion and to determine the severity of the grade, what we went over just a couple of minutes ago, because that's the most important. You never want to scan a dog, find a disc, perform surgery, and this wasn't actually the problem. So this is why the clinical exam or the physical and neurologic exam is so important in general in veterinary medicine. So how does a cervical disc look? Usually dogs have only neck pain. How we see neck pain is by a low head carriage. If they look at you, I do I offer them a little treat. And if the dog cannot lift its head to pick up the treat, but rather rolls his eye up, you know, to try to see and try to catch the treat, this is for me a sign they have neck pain. They have the kyphotic posture on their back. So often we get called by owners that I think my dog has a back problem. It's actually a neck problem that just looks so kyphotic because they guard their necks. And then obviously the stiff and rigid, trying to not move their head and neck, cannot shake their head and neck, so just being like a little bit more stiff. Some dogs are as severely and strongly affected as actually having such bad muscle spasm that they may look like seizures, but they are just having such severe pains that the neck muscle spasm so bad. Nerve root signature is a big one as well because it can look like an orthopedic disease when dogs have a low cervical slip disc and they rather hold their leg up than drag it behind because they have that tinkling sensation in their paws. So what we call nerve root signature, they just don't want to place that paw down. Looks like an orthopedic disease, but it's obviously not in that case. A tetraparesis is when they become weak in all 4 limbs. When we have a caudal cervical lesion, they have rather a 2-engine gait. Because we said earlier, when we have a C62, they have a lower motor neuron gait in their thoracic limbs, so a short, choppy, strided gait, but an upper motor neuron gait in their pelvic limbs, so the wide-based circumducting steps. So this is why it looks, we call it a 2-engine gait because it looks like the dog runs on 2 different engines. And then many dachshunds have slip discs in their neck. Actually, a Frangie more so than a dachshund. Also said that most recent study, small breeds rather high cervical, large breeds rather low cervical, but you know, exceptions make the rules. We see it all, like a C71 disc, it happens as well. Slip discs in the neck are super rare in cats. I myself only saw 3 cats so far with slip discs, so it's definitely not as common. Clinical signs for thoracolumbar discs are now, they range from back pain to being weak in the pelvic limb, what we call a paraparesis, to being completely impaired in their pelvic limb, so paraplegia. So those are the 2 different pictures I placed here. So this dog is weak, it knuckles in its paws over, but there's still some strength to kind of hold himself up, whereas the other picture that he's just dragging his legs behind. Once dogs have lost their motor function to the pelvic limbs, they can no longer control the urination either. So very important to recognize that a completely paralyzed dog needs bladder expressions, because the innervation runs through the spinal cord as well and to the urinary bladder. So really important that we don't have run in any troubles with like the detrusor atony, or even like in a terrible case scenario, a ruptured urinary bladder. Most of the slip discs are between T11 and L2. So we said earlier, cranial to T10 is less likely because of the intercapital ligament. Anything is possible, but it's super rare. And slip discs in cats are even more rare. If a cat has a slip disc, then actually most often at L4 or 5, I feel. But again, anything is possible. And then myelomalacia, we'll touch upon myelomalacia in a few minutes once more, is always a concern when a dog is a category 4 or 5, especially with an acute onset. But again, we'll talk about myelomalacia in a few minutes. So this is how we determine if a dog has or doesn't have deep pain perception. So what I do in this video, I use the mosquito forceps and I clamp it down on the bone of his toes. He does pull his leg back, as everyone can see, but that's a reflex action. This does not count for deep pain perception. Clearly, this dog has no idea that I'm doing this right now. A dog which can feel his legs would not for a third time tolerate me doing that. He would rather now get real angry and try to bite me. So that's the most important take-home point, is reflex does not equal intact deep pain perception. So because actually on that point, because the dog pulled his leg back and had a reflex action, meaning we have an upper motor neuron to that pelvic limb, this dog was a T3L3, to just kind of spin a small circle back to the beginning of our presentation. So real briefly, the clinical signs to lumbosacral disease is often either just lumbar pain, so being hesitant to jump in and out from a truck or walk up and down stairs. Some dogs, they show low tail carriage because the tail innervation comes from the L4 S3 spinal cord segments, where we worry the problem comes from, so they cannot wag their tail or they have a hard time doing so. Pelvic limbs can really quickly be atrophied. We said the denervation atrophy happens real fast, so the hamstring muscles get real quickly lost. Urinary and fecal incontinence can often happen because, again, the urinary bladder and the distal rectum and anus is innervated by L4S3 as well. So it's a big problem as well in the lower lumbo or lumbosacral spinal cord problem. Most often we see a type 2 at L7S1. So kind of just to keep in mind, if you have a German Shepherd with a low tail carriage and maybe some muscle atrophy, plus or minus some pelvic limb neurologic deficits, as in proprioceptive deficits, probably a type 2 disc, but doesn't have to be, obviously. So how do we diagnose now? We said we have 4 types of discs. We've gone through how to localize where the problem comes from, what are the most important clinical signs for each part of the spinal cord segments, and now how do we diagnose what's going on? So survey radiographs are often useful to rule out either advanced infections of the bone, so discus spondylitis, or dogs hit by a car. We want to make sure they have no fracture or luxation or subluxation. Sometimes we see bony changes, so osteosarcoma. Obviously, then we are glad we did spinal rods before we perform an MRI scan, because if the spinal radiograph reveals the answer, this may, for some owners, be the end of the road. Often we see narrowing or wedging of the intervertebral discs on the foramen. So narrowing just suggests that in some point in time, that specific disc has degenerated and maybe bulged a little bit. Whether this was yesterday or 3 years ago, it is impossible to say just based on a survey radiograph. And then we can see mineralized tissue in situ, as with the green arrow pointed out here, just shows us this, the disc has degenerated. Actually, we found out that a dachshund as early as 1 to 2 years of age already can have mineralized discs. Doesn't mean he has a slip disc. It just means that the nucleus pulposus degenerates and already mineralizes. Tiny tip: the T10-11 intervertebral disc space is more narrowly physiologically. So this does not mean he has actually a narrow disc space here. This is normal for that dog. CTs become more and more popular. This can be performed with or without a myelogram. A CT is great to look at the bone, and a CT is definitely the advanced step to an X-ray. The problem, though, with the CT is that I can't appreciate anything what happened to the spinal cord itself. If the disc is non-mineralized, and we said we have out of the 4 types, actually only one of them is actually a mineralized type. So do we miss those, or do we see a mineralized disc and we don't see the non-mineralized disc? So it's hard to differentiate what is maybe the exact problem. So then we thought, okay, we'll solve that problem by just injecting some dye into the subarachnoid space to see where do we have a void of a flow. But obviously this is a risk. So we inject something into a very delicate structure. If the injection goes wrong and it ends up in the spinal cord, it's obviously a big problem. So the ultimate solution is to do an MRI scan. So the MRI is beautiful in that I can see the parenchyma of the spinal cord, so the integrity. Did the spinal cord get injury as well? So do we have a bruising of the spinal cord because of that disc? You know, do I have signs of myelomalacia, for example? Or maybe do we not have a disc and we have an intraparenchymal pathology, like spinal cord tumor, MUE, any other things like discus spondylitis, all those changes. I can also see how much hemorrhage is actually associated. Sometimes the disc slips out between 2 vertebrae, but it ruptures a vessel on the way up, and it actually causes massive hemorrhage along an entire like 3-4 vertebral length. So if we do surgery, we open everything up to decompress the entire compression. So that's quite important to all identify that on an MRI scan. It also helps us if a dog has multiple discs to identify which one is actually the one which causes the biggest problem. So the MRI is superior in all of that, and this is why here we would always perform an MRI scan over CT scan if we can. These are 4 different MRIs, and this is just a little bit to show you what actually are we looking for when we have a disc. Obviously, you know, the talk is not made for talking you through all kind of spinal cord problems they can be, but those 4 different types of discs, they appear so very different on MRI scans. This is the extrusion. So again, same landmarks as earlier. Dorsal is on the top, ventral is on the bottom. The left is cranial, the right is caudal, and every single of those 4 images are aligned the same way. The extrusion is here of the degenerated, dehydrated nucleus, which causes here a bulging and a compression from ventral of the spinal cord, versus the protrusion is more like a small bulging up, and we can also appreciate on that protrusion how ugly the disc looks already in every aspect of the disc. Versus the ANNPE, this was the picture from earlier, the shorter and smaller nucleus, but the presence of the nucleus, and then this massive spinal cord bruising associated with that. And the ANNPE, so the seagull-shaped, hydrated, but compressive nuclear material. How else do we know that this is compressive? The dorsal CSF flow here is interrupted. So this means this spinal cord is being pushed up against the dorsal wall of the vertebral canal. So that's just briefly, obviously, nobody needs to be an expert on reading an MRI, but I want to share with you of what we're actually looking at when we do MRI scans. So how can we treat slip discs? There are basically 2 ways. Number 1 is a conservative approach. What do we actually treat conservatively? Either a dog which had for the very first time in their life a very mild neurologic dysfunction, or just shows signs of pain, so never had a problem beforehand, is able to walk and pee and wag the tail. So you say, sure, let's give it a shot and treat that conservatively. We also treat conservatively dogs with discogenic pain. So if there's not much of a nucleus rupture, so if there's not much of a compression, we say, okay, let's fair enough to give that dog a chance to avoid surgery before we need to be invasive. So those dogs get the chance to heal conservatively, meaning analgesics, very, very, very strict cage rest. So there's no mercy. Those dogs go out to pee and poop, they come right back into their crates. They eat there, they sleep there. They need to rest, and the scar tissue around the disc needs to form. Often we involve some rehab, and if a dog is overweight, obviously that's the most important part, is some weight control. If the problem is in the C-spine, we obviously don't want to use neck leads anymore, as you know, we don't want to yank them on the neck, so we just fit them into a chest harness. The other way we approach actually slip discs is with surgery. So when do we do surgery? It's either if conservative management failed, so the pain is too uncontrolled, or the neurologic dysfunctions get worse, or it's a recurrent problem. So the fourth time over the last 3 years we have signs of back pain, it's time to do surgery. When a dog presents to me being a category 3 or worse, I'll do surgery on those dogs, and I would do it in the middle of the night. So no dog for me in a 3 or worse sits overnight and potentially be at risk to develop or to turn into a category 5 over those 4 hours waiting until it's the morning hours. So I get up at night, I for sure will do surgery. The patient comes first at all given times here. What do we do? It's either dorsal laminectomy, a hemilaminectomy, or a ventral slot procedure, depending where's the slip disc, how did it slip, and you know, how do we get the most material out and decompress the spinal cord. Complications are like with any surgery: hemorrhage, infections, seroma formations, you know, any anesthetic complications, and then specifically to the disc is the incomplete removal of the disc. So you know, there are actually studies on the percentage of very experienced surgeons having a disc material left behind. So we want to be triple and fourth time checking that we've removed all the discs. And constrictive fibrosis is a problem, you know, or like a pseudolaminar formation. So for me, every dog gets a gel foam layer between the disc, the spinal cord, and the muscle layer. So I don't want to have any problems on that extent. Super rarely instability. I guess if you follow the clear instructions on the width and length, we can do it. I think the instability should be of no concern. So a ventral slot procedure is performed obviously from ventral, hence the name. A ventral slot means we are creating a tiny bony window, which is a third in width and a third in length over the disc space. So just enough space for our very tiny hook to introduce and scoop out all the herniated disc material. The approach is real delicate because we are going through trachea and esophagus and the vagal nerve and the carotid artery and the jugular vein and such. But with the sufficient anatomic knowledge and the loops we're using, or the microscope, obviously you see all the structures, so this shouldn't be a problem. The nice part in a ventral slot is that we don't really cut through much muscle mass. So dogs recover super well and easy, and they usually don't hurt much after surgeries. For the thoracolumbar discs, we most often do a hemilaminectomy. So this means now we create a small bony window on the side, so on the lamina. The lamina should be, like in this post-op CT scan, be as ventral enough and as dorsal enough to actually really decompress the entire lamina and the entire spinal cord. We can scoop out all the disc material, and it allows us to have enough exposure so we can fenestrate as well. So that's the surgical approach for a thoracolumbar disc. And then for the lumbosacral is most often a dorsal laminectomy. So obviously not one size fits all. We do often hemis in the neck, or dorsals in the neck, or hemis in the L7, or you name it. So we just don't do ventral slots, I guess, in the back, but it's interchangeable depending on how the disc ruptures. But those are the 3 most common types on the 3 most common spots. What do we do post-op? So I always keep my dogs a minimum of 3 days, sometimes even longer in hospital. And the goal for me is to also observe initially that they recover from anesthesia, they're comfortable, they get the nursing care, so icing, they get immediate pain management, not just with a chemical, so like an FOK drip, and then oral medications, a tramadol, gabapentin, some Valium, even anti-inflammatories. But we also do early post-op rehab here, TENS units, some laser. So the main goal is to get that patient as comfortable as possible, as fast as possible, and to give all the nursing care needed. Optimally, they start urinating on their own, and we witness that before they go home. If that's not possible, we need to teach owners very carefully on how to monitor bladder function, as a dog, like I said earlier, which is paralyzed, cannot urinate on their own, so they need obviously pain management, bladder care. After 3 to 5 days, they go home, they're discharged then, and they need to be cage rested very strictly. The first 2 weeks are for me the most important one, and then a total recovery time of 6 weeks where they're not allowed to jump, run, play, and be like all crazy themselves. A little bit pain meds orally for at-home care is usually discharged with them as well. Physical rehab, like I said, is important. In human medicines, it's a normal standard, and here it's 7 as well. So every post-op patient immediately has rehab when they come out of surgery, and optimally even for the entire period of time until they're back to normal. So for some dogs, it's 2 weeks. For some dogs, it's 6 weeks, depending on an individual case. And obviously, it's very individually tailored to the specific dog. For prognosis, and this is obviously the most important part for owners also, and for us veterinarians and neurologists to share. As long as a dog is a category 4 or better, if we perform surgery soon, or like with as long as they are a 4 or 3 or better, they have an 85 to 95% chance of full recovery with surgery. The number is great. You know, this is a no-brainer. If the deep pain perception is absent, so they lose deep pain perception, they're category 5, there's still a 50% chance that we get them up and walking as long as we perform surgery within 24 hours. The chances shrink dramatically every hour we're losing. So after 2-3 days, the chances are so slim of getting them walking again. So time is of the essence, especially if they're category 4 or 5. Conservatively managed, 50-60% can get better without surgery, as long as they're 4 and better. I feel like the better the less the category, so 1 and 2 has a better chance than a 3 and 4. Once they are 5, like the 5%, I think is a very positive thinking. I often feel like it's even less than that. So conservatively managed category 5 dogs, unfortunately, is not the greatest chance. So like we said, we categorize everything between 4 and better or 4 and worse, meaning the pain perception is the most reliable prognostic indicator for the recovery, and recovery meaning independent, running, playing, being comfortable, going to the bathroom on their own. If the pain perception is not returned within 4 weeks, after with surgery or without surgery, I usually are then discouraged. So nerve recovery can take up to 4 weeks. After 4 weeks, I fit them into a wheelchair at that usually. Recurrence rate is also a topic, and owners do need to be educated that there is a recurrence rate. So even if you do surgery at one spot, the dog recovers and he does well. There's so many discs in a dog, you know, any other disc can rupture. Surgically treated is 10 to 15%, conservatively managed up to 50%. And this can be, so that's the reported 6 months to 1 year, but it can happen anytime, like 8 years later or any other given moment. The prognostic factor for recovery of urination is kind of similar to that of ambulation. And like we said, anatomically, urination and motor function almost comes on the same page. So the recovery for urination is equal to that of ambulation. And then urinary bladder infection is very important, that a dog which is paralyzed is more prone to have UTI. So we're just going to keep an eye on those dogs which are chronically paralyzed. Very briefly, before I guess I will give you then also some time to ask a few more questions, to talk about myelomalacia. Myelomalacia is the terrible condition, the necrosis of the motor fibers and the sensory fibers. And it usually, so myelomalacia means melting of the spinal cord. If that ascends, so these are the clinical signs we look out for the ascending myelomalacia. As it ascends more and more cranial, they eventually become unable to be in sternal recumbency. And once they lose their weight, their ability to bear weight in the thoracic limbs, we worry that in a few more hours, they will be unable to breathe. So usually at that point, we have to let those dogs go. Myelomalacia is a concern for any dog which is a category 4 or 5 in a very acute onset. So 5 to 10% of patients develop myelomalacia with or without surgical intervention. And owners need to know that before we even go into surgery. Still, surgery is the way to go, but myelomalacia can happen 4 or 5 days after surgery if everything even if everything went well until that point. So can happen up to a week after onset or after the spinal cord trauma, but it's obviously a big topic. So here on the MRI scan, the disc rupture happened up here, but all the hyperintensity caudally is evidence of myelomalacia. In the upper image, there's just a focal myelomalacia. If I see that, I share this with the owner that I'm very concerned about the myelomalacia development in those patients. So I technically have here a case report, but we're running short on time, so I want to skip ahead to questions because I feel like those are more important to answer, and then also to have you like write down our phone numbers in case you don't have them, in case you have a question and you want to reach us and talk to us. Perfect. So the first question here is was written for an initial episode of IVDD on a conservative care, what medications would I choose and what doses would I recommend? So I think it's a fantastic question. So my go-to medications are always tramadol and gabapentin in case there is not a contraindication. So a pancreatitis dog doesn't get tramadol from me, but an otherwise healthy dog, there's tramadol and gabapentin initially. Tramadol at 5 mg per kg 3 times a day, gabapentin at 10 mg per kg 3 times a day. If that's not sufficient, I often add in Valium, 5 milligram per kilo 3 times a day, especially for dogs with neck pain. I think Valium is great for muscle relaxation. And so an anti-inflammatory, so whether this is a steroid or non-steroid, really only I choose if an owner cannot move forward with an MRI scan and we have no other way how we can help. So I want to avoid using anti-inflammatories if I can, at least initially. So I hope that helps with that question. The other question is, for how long do I recommend such strict rest? And when I treat a dog conservatively, and how soon do I start rehab? So I think it's another really, really fantastic question. So strict rest, conservatively managed, is for 4 weeks. And then the following 2 months. So the first 4 weeks is strictly rest in a cage. The second 4 weeks is actually in a small room or a very large playpen. The third 4 weeks is then in a one level of the house. So for a total of 3 months, they're not allowed to jump and run and be all crazy, no dog parks and such. So that's for the conservatively managed dogs. Rehab, I usually start after 2 weeks because I feel like the first 2 weeks are really essential for scar tissue development. And rehab can be started sooner if done by professionals. So a rehab specialist, they can immediately start because they know how gentle and how fragile our open rupture disc is. But for owners to do rehab at home, which many owners do, you know, there are really great videos out there for owners how to learn to do some passive range of motion, assisted standing and such. We let them do rehab at home, but for those cases, I would typically wait for the first 2 weeks. So there's another really great question. It says here that I mentioned it may take up to 4 weeks for nerve to regenerate. What about the muscle atrophy? So yeah, I think this is a really great question. So muscle atrophy is a big topic when dogs are cage confined. So we want to have them rested because they need to heal from a slip disc, but now that their muscles denervate and atrophy from disuse. So muscle atrophy, to rebuild that muscle mass, usually takes twice as long as it took for it to be lost. This is where rehab is hands down most important part. So we rest them for avoiding a re-injury or worsening of the injury, but we have to counteract that with a controlled and very gentle physical rehabilitation. So I would say the rebuilding of muscle mass can sometimes take 2-3 months. The sooner we interfere with the physical rehab, the less actually severe gets the muscle atrophy, and the less long it takes to recover. If a dog is not recovering the feelings in the legs, so let's say the dog remains paraplegic, those muscles will not come back. You have to have a nervous innervation for muscle mass to build. So unfortunately, those dogs, you see them in a wheelchair the paraspinal muscle caudal to that injury and the pelvic limb muscles are just, they remain atrophied. So I have another question here. It says myelomalacia can happen naturally even with conservative management. Yes, it can, and with surgery also. So yes and yes is the answer. So myelomalacia happens because of the speed of the disc rupture, because the secondary injury to the spinal cord. So the spinal cord is being smacked, so it causes just a massive concussive injury. The secondary changes, so the oxygen-free radical formation, the excitotoxicity, the inflammatory cells, so all the things which happen secondarily to that bruising is actually what is the cause of myelomalacia. And that can start, that process of the secondary chain reaction can start within hours of the injury. So let's say the dog got paralyzed throughout the daytime when the owners were at work, walked normal in the morning, they came home at night, he's paralyzed, they straight come to us, we perform surgery. That chain reaction has started. So myelomalacia can happen even if we do surgery, but it definitely can happen with conservative management. So if in doubt, I would rather err on the side of surgery, because I feel like when we decompress the spinal cord, we take away part of what the spinal cord needs to battle. So the compression and the concussion has to heal by itself. The compression, obviously we can do some, but for all statistics sake, yes, it happens with conservative and with surgical approach to discs, to slip discs. So one more question I think we can for sure fit in, or maybe if I speak even faster, maybe a second one. How do I feel about laser therapy for IVDD? So laser is perfect for wound healing. So after surgery, I love laser. I think my incisions look great. They heal real fast. It seals up so nicely. Often by the time I remove sutures 2 weeks later, you know, you barely see where the incision was in the first place. To have that help, or it can relax the muscles when their spasms roll heavily. So when the dog is so painful, it may help them to feel better. Laser does not reach the disc. So when we do laser on top of the back, it has to go through the bone of the vertebra, bypass basically the spinal cord, and then reach the disc down below. So the laser beam we are using is not strong enough to actually do anything for the disc itself. So I think laser has its point post-op or in conservative managed dogs to improve pain control, but I don't believe it actually makes the slip disc treated. I don't think it's a substitute for surgery. It can be like in conjunction, can be as an adjunctive modality. I think it has its points. So we'll do one more question, and the remainder of the questions I will get to by email. So, and I promise I'll get to all of your questions and we'll email you. Just we're running a little bit short in time, but this very one last question, what I want to address here. Is there a way to test puppies or parents for IVDD? And so there are actually studies where they measured the length of dogs' legs. So the dachshunds were qualified of how long is the tibia as compared to the entire length of the leg and to the back. And there was a little bit of a correlation. The shorter the length of the leg and the longer the length of the back, the more likely they're going to have IVDD. There's otherwise no real genetic marker to say, okay, this dog for sure will have a slip disc, but more and more recent 2019 and 2020 papers actually are looking into that. So I think soon we're gonna maybe have a better idea. But the caveat is that if I have a 1-year-old dachshund, let's say presents here for seizures and it has actually epilepsy, we take a spinal radiograph and it has 3 calcified discs. It doesn't mean he will have disc disease in his future. It can obviously mean that we should be worried that they calcify so early in life. But yet, if a parent has an IVDD, doesn't mean the puppy needs to have it or not. I think the breed predisposition, so Dachshunds, Frenchies, Yorkies, Malteses, those are rather to keep a close eye on it. But I believe in a year or two, we're going to have some genetic markers. Like there are more and more studies coming out. I'm very optimistic on that. So unfortunately, I think we are up with time now, and I'll scan through those questions and definitely going to email you with some of those answers over the next couple of days. And don't forget, within the hour, you can get your CE certificate. So if you wouldn't get your CT certificate, just email us and we'll get this over right to you. And if you have questions in a week or so, just email us anyways. I'll be here. So bye for now, and thank you so much for participating and have such great questions for me. I loved it. Bye, guys.